Hey everyone, my name is Emaan Chaudry.
And my name is Danielle Solish, and today you're listening to the 21st episode of Seeing Clearly, a pre-clerkship guide to all things ophthalmology. On today's episode, our 21st episode, we are going to be introducing and interviewing Dr. Nupura Bakshi. So I'm going to start by telling you a little bit about Dr. Bakshi. So she is a medical retina and uveitis specialist and an associate professor in the Department of Ophthalmology and Vision Sciences at the University of Toronto. After her residency training at U of T, she completed a fellowship in both retina and uveitis at the National Eye Institute, the National Institutes of Health in Bethesda, Maryland.
So Dr. Bakshi also has a special interest in medical and surgical education and advancing equity, diversity, and inclusion in medicine. She's serving as the inaugural chair of the EDI Working Group for the Canadian Ophthalmological Society. She is the vice chair of clinical services and quality for the Department of Ophthalmology and Vision Sciences, and is a member of the Diversity Advisory Council for the Temerty Faculty of Medicine at the University of Toronto. She's won multiple teaching awards for her efforts in training residents and fellows. So we're really excited to have Dr. Bakshi here today, and we're so excited to introduce you. Thank you for being here.
Thank you so much for having me. I think this is wonderful that you guys are doing this podcast and all the work that you're doing to really create that community of people who are interested in ophthalmology, and I'm sure that it's going to have a huge impact. So thank you for having me.
Thank you for coming. We're very honored to be speaking to you. We always start off with the same question to all of our guests, and we're just wondering if you could talk a little bit about your journey to ophthalmology and why you really chose ophthalmology.
So I think I came into ophthalmology a little bit accidentally. When I started medical school, I wanted to do pediatrics. I really thought I wanted to be a pediatrician. And so I was, trying to do stuff to try and get into peds. And I thought, okay, I'll do research after my first year summer. But I really wanted a clinical project because I had done like preclinical research and like lab research with the mice and all that stuff. And I was like, I just want a clinical project and I don't want to be in the lab. And I applied to like 30 projects in peds and one in ophthalmology. And the one I got was one in ophthalmology. And I just picked it because the project sounded cool. And then I started doing that project, and I got to spend a lot of time as well with the residents in clinic, and that supervisor, as well as the time I spent in clinic, really introduced me to ophthalmology, and I got to see what it would be like as a career, and I got to work with residents who were amazing, and I think that's when I thought, oh wow, this is really neat. It's a lovely mix of medicine and surgery, and you get to actually see the pathology literally. I mean, you get to see the disease manifesting in the eye. You're not relying on labs to see what it is. You can actually see the changes in the eye, and obviously the impact of vision in somebody's quality of life is so fundamental. And I was hooked from there moving forward, and then that's basically how I started looking into ophthalmology. So I think in my second year of medical school, I guess. Although I would say I was somebody, and I think I still have a lot of interest, and I think I would have been happy. I love doing ophthalmology, but it wasn't like ophthalmology do or die. I also liked other areas of medicine, and I think I would have been happy. Maybe I would have had a completely different career, and who knows what would have happened. I think everything worked out as it should. But I think there's so many beautiful things to so many different aspects of medicine, and it's just finding that niche that you think fits for you, and that people can have more than one niche. So I think that's something I would really love to pass on to the listeners. Obviously, this is people who are listening to this are probably interested in ophthalmology, but I think that you can find areas of medicine that speak to you across the board, and it's if you get into ophthalmology, great, but it's not the end of the world if there's something else that you like as well. That's how I felt.
Well, thank you so much for sharing that. I feel like for myself and Danielle and then all of our listeners, it's really reassuring to hear that advice, but it's also nice to see that you kind of stumbled upon the specialty and then fell in love with it. It speaks a lot about the specialty and how captivating it is. So thank you for sharing that with our listeners. We mentioned briefly in your bio that you're a retina and uveitis specialist. Do you mind maybe telling our audience a bit about what that means and what a day-to-day in your job looks like?
Sure. So I did 2 fellowships, one in retina and one in uveitis. So that has created a really great mix to my practice. So I do regular retina, which is, diabetic retinopathy, retinal vascular disease, macular degeneration, the bread and butter of retina, medical retina. I'm not a retinal surgeon. I do cataract surgery, but I do medical retina. And then I also do uveitis, which is ocular inflammatory disease. And the area where those two meet is posterior uveitis. So inflammation of the retina, of the choroid, of the retinal vasculature. So which is arguably the most severe, the highest risk of vision loss, and also some of the hardest to treat forms of uveitis. So I have like a very subspecialized practice in that as well. So I think what I love about my work is, one, the varieties. So every day can be completely different. And also I have a part academic, mostly academic, and a part community practice as well. And what I love is teaching the residents and medical students. I teach almost every day, and around clinical teaching as well as some didactic, but a lot of clinical teaching. And I think that keeps me enthusiastic and it keeps me engaged, because sometimes it's easy when you are doing, you get used to your practice and you're seeing a lot of patients, and especially now, with coming out of COVID, the volumes are insane and everybody's so busy and the burden of disease is so high because people haven't had adequate care for a long time. And so it's easy to get tired or bogged down or see like, oh my gosh, just another patient with the same condition. And then I think having the residents, seeing the residents be so enthusiastic and engaged, and they ask questions and they make you rethink, oh, well, what about this thing? Oh, why is that, this way? And I think it really keeps me interested. So I really do love the teaching aspect of my job. My week is variable. Certainly I have days where I'm operating, days where I'm in clinic, an academic clinic, days where I'm doing all uveitis. I have one clinic that's just posterior uveitis, and it's all these complex cases that are referred from other retina specialists. And so, we have sometimes up to 6 or 7 learners in that clinic. So it's really a very coordinary care clinic that is really interesting. But if I had to do that every day, I think my brain would be exhausted. And then I have my more regular medical retina, follow-up patients for more routine care. So I really love the kind of flexibility and variability of what I do. And then I also have I probably see about patients 3.5 to 4 days a week between clinic and OR. And then I have the other day where I do my leadership work, my academic work, my administrative work.
That's incredible. It's nice because we hear about all these different specialties within ophthalmology, and we've had staff from different specialties speak to us, but it's incredible to see how you can like take these 2 fellowships, put them together, and have this variability while also teaching and doing all this other academic work. It's so very impressive, and also just like nice for individuals to know that there is, within ophthalmology, there's so many different paths that you can take to make the schedule as individualized as you'd like. So thank you for sharing that. On that kind of note of, making an individualized schedule and, working on your own initiatives, I was wondering if you could talk a little bit about your work on COS, like the Canadian Ophthalmological Society with the EDI Planning Committee, and, how you got involved with this and what's it like?
So I think my journey to EDI actually started well before the work that I did for the COS. But when I really started doing it at the local level because of my own experiences as a woman in medicine, as a racialized woman in medicine, and also that I kept hearing from our residents that these things, they hadn't just happened. I guess I've been in practice for 12 or 13 years now. So these are things that not just happened a decade or more ago, they continue to happen to this day. And I would hear that from our residents. And I think that it made me realize that if we want change, that I also need to be a part of that change, and I need to be an advocate and a champion for change. And I think that's when I really started to think about working in EDI more formally, not just at the individual level where I, was a mentor or, a resource for other residents, but also just really at the system level, at the institutional level. And then I thought, I have agency, I can do something about this. And so that's really when I started to think about more formal work in EDI, and I started doing it locally for our department. And then I soon saw, though, that there weren't many people in ophthalmology doing this work at all yet. and that there really wasn't a national structure for it as well at that time. I mean, this was only a few years ago. It's not like I'm talking about a decade ago, literally only a few years ago. And so I realized that there's a huge need on a national level, and really that's how it started. So I actually I created kind of a strategic plan for EDI in ophthalmology, and I presented it to the COS and to the executive director of the COS, and she took it back to the board, and it was basically unanimously approved. And I proposed this creation of a working group to kind of bring people together who had interest in this area. And I was very humbled when they asked me to lead it. And so that's really how I came into this work in a formal way. But I think there's such a huge need, and we're still at the beginning of this work, but I've really been so happy with how supportive the COS is, and everybody I've encountered really has been so supportive. And I think that also is reflective of a cultural change, not just in ophthalmology or in medicine, but just broadly because of national, international events that have occurred that highlighted the inequities that are in our society and the need for EDI.
Well, congratulations on the position, and also thank you for spearheading that initiative. It's one thing to recognize that action needs to be taken, but it's another thing to actually do it. So thank you for being a part of that and for doing that. I just wanted to ask, what does the future of EDI with COS look like? If you can give us a glimpse into kind of what you guys are working on.
So, I think, what is the ideal future? Like the goal is to really create and foster an environment and a culture where there's equity of opportunity for all Canadian ophthalmologists, including and especially those that are from groups underrepresented in medicine, and to really have a diverse workforce, but not only to have the diversity where people can bring their whole selves and all of their identities to work, but also to have that in an inclusive environment, where they really all have, equity of opportunity, and not just that, but they're welcomed, their identities are welcomed. But on top of that, we also know that our society is diverse and multicultural, and we really want to equip all ophthalmologists with the knowledge and the tools they need to be able to provide culturally sensitive care and inclusive care to patients. And I think that other part of it is also really important, because we're all going to, provide care for a huge diversity of patients over the course of our careers. And so I really think that that's another important aspect of it. And of course, that is going to come from knowledge and education and discussion and community. And so helping to create that community and really change the framework or change the paradigm that knowledge in EDI is as important as knowledge of cornea or as knowledge of retina or whatever else, that this is also a core competency of medical education and ophthalmic education. And I think I would down the road, and this is not just part of the COS, obviously, educational institutions have to be involved in that as well, but to really establish that as a core competency, a core professional competency. And I think, long term, this is going to have a huge impact on the professional working environment of ophthalmologists, but also, more importantly, how we provide care to patients. And I think that those would be our long-term goals. Of course, this is not a 2-year plan or a 5-year plan. This is a long-term plan. And so, we're trying to approach it from a multifaceted angle. We are looking at education. We had our first ever EDI symposium last year at the COS, and that's basically been approved by the board to happen every year forever. So education is a huge part of it, but obviously policies, advocacy work, and then diversity and representation. We right now, our ophthalmology, it's getting better, but there are certainly significant areas of lack of diversity within ophthalmology. And really, that is something that has to work even, we have to start that work even before the medical school level to improve the diversity into medicine, then into ophthalmology, and then into subspecialties, because some subspecialties are, have very different demographic profiles than others. So there's a long way to go, but certainly diversity and representation is one of our key projects that we want to tackle as well. So, sorry, that was a very long-winded answer, but I have a lot to say on that topic.
That was an incredible answer. And honestly, it really changed the way that I'm thinking about it right now, in terms of you're not just treating the patient and their medical condition, but, you're including EDI and all your EDI initiatives into all patient care, into all interactions that you have in medicine and outside of medicine. So, that's absolutely incredible. And I'm sure that's an incredible learning point towards everyone within the field of medicine, that you're already sharing and starting this initiative now. It just takes that one person to be that first revolutionary in the topic to go forward with this. So thank you.
Well, one of the things that I think about, if we think about the patients we serve, we are every day serving patients who have invisible or visible disability, visual disability. And yet I think we don't really spend a lot of time in residency or in our medical education talking about how to care for patients with a disability and provide inclusive care. And that's literally what we do all day long. I mean, almost everyone we see has visual impairment. And I think that that's just the beginning, really looking at an inclusive model. But as ophthalmologists, that should be a huge priority for us because that is our patient population.
Yeah, for sure.
100%. And, I know even just like at a medical student level, like we only just started talking about like disability and inclusion within like the last year. And, it's definitely been a delayed process. So 100% it should be embedded in, in ophthalmology and all specialties. You're always treating the patient, their disability, who they are, and their backgrounds, for sure. Switching gears a tiny bit, I was wondering if you could talk a little bit about what it's like to be a female surgeon and like any challenges that you have specifically with that.
So this is a great question. So I think being a woman in medicine definitely does have its challenges. I think that it's just one identity. Like, I'm also a woman of color, and that's another aspect to it. And I think, intersectionality in how our identities come and how they interact and create challenge, I think is important to mention as well, because I think that's also part of, having an inclusive environment. Yes, have I had challenges as a woman in medicine or a woman of color in medicine? Absolutely. Many times I'm the only woman at the table at a meeting or on a panel. Retina in particular is the worst subspecialty in ophthalmology in terms of gender representation, and there's literature on that. And so, there's definitely work that needs to be done, and sometimes it's hard to convince people that there is a problem, people being the people who are currently in the majority. And, I think there are challenges sometimes at a system level and at the individual level. So, at the individual level, I would say sometimes I get, for example, referrals for patients who are perhaps require more chair time or, have chair time. So that's what we talk about, patients who sometimes need additional time for discussion, or, it's not so much about the pathology in their eye, but it's about that patient bringing their whole selves and what they need for that care. And I think oftentimes, not just myself, but women often get the majority of those referrals because we're seen as being, either more compassionate or having more time to talk to patients. And so that also contributes to the gender pay gap, which, I'm sure, I think some of your other speakers have mentioned in the past. I think that in terms of how to address these challenges, I think one of those for me has really been finding my own voice and really being able to speak up and really having that sense that I cannot complain about the problem if I'm not willing to be an agent of change. And so that's really what I told myself and what really made me think that is really seeing that, the problems were still happening with our residents, and, residents were still reporting microaggressions and macroaggressions and discrimination and harassment, and that's not a pleasant learning environment. And so we really, thought this has to change, and I wanted to be one of the people who helped to change it. And so finding my voice has been a big thing for me. Also, I think community has been really huge. Community of support, finding other physicians who are willing to work together with me on these issues, as well as just even to talk about our experiences and have that community, as well allies and sponsors and mentors who are men. I think that's really important. And I would not be where I am without amazing sponsors and mentors, not just mentors, but sponsors who are men who really give me opportunity and put me forward and help me to reach where I am today. I think that's been really critical in my career, and I thank them all the time. I think also, I think women in medicine generally, many of us are mothers, and there's still a societal, paradigm around who cares for things at home. And I think that having a supportive partner, having help at home, having that other community for the rest of your life to work together. And I know, we talk about work-life balance, but I almost feel like it's more like work-life harmony or work-life fit, because that that balance shifts constantly depending on what the priorities are at the time, and really having that network at home is really critical for me to be able to be my best self at work. And I think also time for self-care, interests outside of medicine, my family, those are all things that really help to refresh my spirit and renew me. And I think that as I've come further in my career, I keep telling myself how important that is, that it's self-care, you know, that quote, like self-care is not selfish, because it, you know, it does make me a better doctor and a better mother and a better, you know, human in the end. And so I think that's the other part of it as well, in terms of really dealing with the challenges of being a, you know, women in medicine. I would say though, I think that there's been, if we look at all of the groups that are underrepresented in medicine, women I'd say women in general have had a lot of help compared to other groups. So at least there are women in medicine communities, there's, you know, advocacy around gender equity or creating gender parity. There are other groups that are far less you know, represented in general, plus have far less advocacy, whether that is by race, by sexual orientation, by disability status. So in a sense, like, yes, while I've had challenges as a woman in medicine or a woman of color in medicine, I can't even imagine what it is to be an Indigenous woman in medicine, a, you know, disabled gay man in medicine. And I think there are so many other areas of intersectionality and so many other areas of underrepresentation that deserve the attention that women have gotten, at least to some degree. And they are nowhere near parity in those groups. And I think that's really important to acknowledge as well. So I have so much privilege actually from certain roles and certain identities, and there are others that have even less than I do. And I think that it's important for me to not just advocate for women in medicine, for those groups that even have less support.
It's pretty amazing to see your perspective on all of this. I'm almost like taken aback, just because, you know, not only did you tell us about some challenges, but you really let us know some ways to deal with those challenges, which I really appreciate. And I think our learners will also really appreciate. Like I said, it's one thing to recognize the problem, but it's another thing to change it. And so thank you for allowing us to see kind of how you're dealing with the challenges and how maybe we can go about dealing with those challenges as well. And then again, recognizing that there's still so much more room for improvement, not only with female surgeons, but within minority groups in general. And again, that plays a lot into your role in EDI. And I really appreciate you talking about it. It's really important that we open up that conversation. So thank you so much. Backtracking a little bit, you mentioned that you work a lot with learners, so medical students and residents. A large part of our audience are medical students and residents. So I was wondering if you don't mind sharing some advice for our learners that are listening to the episode.
So I think one of the big things I think is really important is to be authentic and bring your whole self, and really, you know, when we are looking at people we want to be part of our residency program, we really are looking for people who we think are going to be kind and compassionate to patients and are going to be a productive member of the team. Ophthalmology is a small residency, even though in Toronto we have the largest program, but it's still a small residency relative to many other residencies. And that cohesive group of residents working well together and really focused on their education and patient care is really important. And I think that having that authenticity and really being, it's difficult because there's such a power dynamic as a medical student through to a resident, through to a staff, but I think we really value that, and we can see when people are pretending to be either something they're not, or maybe they are so concerned about presenting themselves a certain way to get in, or what they think in their head is like the ideal medical student candidate for ophthalmology, that I think that sometimes it comes off either stifled or inauthentic. So I think just truly being yourself and showing your passion for it. And I think that I think it's also really important to not be so worried if you come to ophthalmology late and you don't know how to use like the slit lamp or the direct, indirect ophthalmoscope. Those are all things that can be taught. The disease stuff can be taught, the exam skills can be taught. We don't have expectations that people come into residency already knowing what a resident should know, because that's why you're there to learn. But but it's really that, interest and passion for ophthalmology or medicine, and really having that desire to work together with a team. I think those are more important. And also, I think it's important to have kindness and compassion towards everyone, not just, of course, the patients, other learners, the support staff. Ophthalmology is also a small community, and sometimes we will hear from a secretary that somebody was rude to them on the phone when they were trying to set up an elective, for example. And I think having generally not just doing it because it's it's the good thing to do, but generally being we want people who are kind of compassionate to everyone, and I think that is also really important.
Yeah, that's very nice to hear. I know it's sometimes stressful, like for all of us as learners, when we don't get so much exposure to like a slit lamp or any of the basic ophthalmology skills. And it, it's kind of reassuring to be like, well, you also have to like think of like who you are as a person and who you're there to treat, and like bringing the initiative and being proactive, and all of those things that you had mentioned. It's great.
Yeah, I mean, I think we can tell when somebody's enthusiastic and wants to learn, whether they know it or not yet, that's okay.
Exactly. So thank you very much for sharing that. And that actually wraps up our academic like questions from our podcast. And as most of our listeners know, we end off with our would you rather questions. So I'm going to begin. I'm going to ask you the first question, then Emaan will ask you one after. But
Sure.
My question for you is, would you rather give up air conditioning or heating for the rest of your life?
I would rather give up air conditioning. I'm not one that does well in the cold. I'm okay being warm. I don't know if it's my like cultural heritage of somebody coming from a warm country of India, but I'm thoroughly bundled in the winter. So I'm okay without air conditioning, but without heating, that'd be a problem.
And Toronto has a long winter, to be honest.
Yeah, I was gonna say, anywhere in Canada, I'm sure you want heating. Okay, for your second question, would you rather have to work in a different city every year or have to stay at the same center for the rest of your life?
Ooh, that's a good question. I think different city every year or the same center for the rest of my career. I think I would pick the same center. I enjoy traveling. I love to experience different communities, but I think in a year, probably maybe I'm thinking of it practically, logistically, it's hard to establish a practice and have it get up and going and, create your roles, whether those are academic and kind of get engaged in teaching. In a year, you're just about starting to do that. And then boom, you'd have to shift to somewhere else. Whereas if you're in one place for a long time, then you really have an opportunity to make a significant difference there and really establish yourself both in terms of patient care as well as academics. And also what's really lovely is seeing the progress of our learners. So, seeing how they are from their first year through to their fifth year and how much they've learned. And it's so rewarding to see how you contribute to that. So if I moved year to year, I wouldn't have that and I would miss that a lot.
100%. You
Such
get
a nice
settled in a place. Yeah, exactly. And honestly, that wraps up our entire podcast. So thank you so much for coming. And everyone, thank you so much for listening to this episode of Seeing Clearly, a pre-clerkship guide to all things ophthalmology. For everyone to stay caught up, please check out everything else iCurriculum. We have our website, www.icurriculum.com, and our Instagram @iCurriculum. And Dr. Bakshi, thank you so much for joining us today. This was so lovely and incredible. And I encourage all of our listeners to, reach out, participate in EDI initiatives, and listen to this episode and get as involved as possible.
Well, thank you so much for having me, and thanks to the both of you for doing this wonderful work.
Thank you. Thank you to our listeners. Bye.
Bye-bye.